Hi everybody, I hope you're doing well. I'm happy to be here presenting today to your class this seminar article review. The article we're going to look at today is called Examining Practitioners' Assessments of Perceived Aesthetic and Diagnostic Quality of High kVp, Low mAs, Pelvis, Chest, Skull, and Hand Phantom Radiographs. I know that title is a bit of a mouthful. Hopefully you will learn a little bit more about what this article is about through today's seminar. And let's get started. So hopefully by now you've already accessed this article and you've had a read through, and you saw that the purpose of the study was to test the usefulness of the dose optimization strategy of increasing your tube voltage, or your kVp, while decreasing your tube current exposure time product, or your mAs, resulting in a high kVp, low mAs technique. You will recall from last term learning about the difference between kVp and mAs. So at a higher kVp, the photons in the radiation beam have a higher energy and therefore they're more penetrating. So how does this affect dose? Just take a minute to think about that. Hopefully you were thinking that more of the beam is able to penetrate and therefore exit the patient's tissues instead of being absorbed. Even though we know this as a fundamental principle of radiation interactions with tissue, and despite ELERA, these researchers found that this strategy of using a higher kVp technique was underutilized in the radiology departments at the time of their study and in the locations where they were, which was in London, Ontario, and they wanted to investigate this further to find out why is it that more sites are not employing this as a strategy to help save patient dose. So what they did was invite participants from the sites that were involved in the study to rate a set of images, and there were 12 images used in total. This list of participants included 6 radiologists, 4 radiology residents, 48 radiographers or technologists, 31 student radiographers, and 2 PACS administrators. They obtained images using phantoms, and these are the phantoms that are intended to replicate humans, and in particular the phantom they used had the tissue equivalency of an adult male of average size, so very similar to what we're using in our labs at Camosun College. They also looked at 4 different body regions. They looked at a pelvis, a chest, a skull, and a hand. So the article describes in more detail why they selected these particular parts. So I encourage you to take a look at that, and also to have a look at their literature review described in their introduction, which talks about studies on dose optimization that have been done prior to this one, as that was part of the rationale for why they chose what they chose, as well as adding in additional parts that may not have been previously examined. For this study, they used a mobile digital radiography system, and they obtained 3 images for each phantom part. You'll notice in the article they described that a 50-inch SID was used, and this was what was recommended by the manufacturer for this particular system. They kept the collimation to be the size of the detector so that it was consistent from one image to the next, and as per their site protocol, they obtained the pelvis and chest images using a 6:1 grid, keeping in mind this is a mobile study, and for the skull and hand they did not use a grid. Now, the purpose of this was to look at how increasing kVp can potentially decrease dose, while also finding that threshold of where image quality would still be acceptable or diagnostic. So they acquired an image at what was called the standard kVp. So that's what would be in the protocol manual or the technique chart for that system at that site. So what's normally being used in clinical practice. And then they added 20 kVp to that for their first dose optimized image, and then 30 kVp for the final image. So there was 3 to compare, the standard and then 2 with an increased kVp. So of course they also had to set an mAs for each of the images, and they did this by using the exposure indicator. So through trial and error, they gradually decreased mAs by 1 setting at a time until the EI value was most similar to the standard image, or that very first image that they took at the regular kVp. So just recall that EI is a numerical value that represents the intensity or quantity of radiation that the detector has received. And this is useful because it allows you, the technologist, or these researchers in this case, to quantify image quality in a sense. And this way it ensures that the images that the participants are viewing are of comparable exposure or quality from one to the next, even though the kVp and the mAs is different. So this is just a snapshot of the full list of technical factors that they used for all 12 images that they ended up including in the study. So this is for the pelvis. So you'll see that the standard image used a kVp of 85 and an mAs of 10, and it had an exposure index of around 1400. You'll also notice this other value on the far right hand side of the chart called the dose area product, and I'll talk about what that is in a minute. Essentially, that was what they used to quantify the dose to the patient. So you'll see that at an additional 20 kVp or at 105 kVp, they found that 4 mAs resulted in a similar exposure index or similar quantity of radiation to the image receptor. And you can see here that clearly the dose area product, or that dose value, is reduced. But when you go to 30 kVp, or an additional 30 kVp I should say, you'll notice that the dose area product doesn't really go down that much comparatively. So that's something I just want you to keep in mind when we get to the conclusions of the study. So the dose value that was recorded is something called the dose area product, or the DAP. And DAP provides an indication of the radiation dose received by a patient. DAP is defined as the absorbed dose multiplied by the area irradiated, and it's measured in gray centimeters squared. You'll see the image on the side here is called a vacuum DAP, so that's one of the options that's on the market. And this device can be attached to your collimator box. When this is installed on your system, DAP can be easily measured by this meter. And essentially it's an ionization chamber that's placed beyond the X-ray collimators, and it must intercept the entire X-ray field for an accurate reading. Once all of the images were obtained, each of the participants was asked to rate the 12 images, 3 for each of the parts, and the order of the 3 images was randomized, so that way it was kind of like a blind study of them not knowing which was which one was the standard image, which one was the kVp. So they had to do this all by their visual perception. So they asked them to rate 3 different criteria. The first one being their perception of the aesthetic quality, the second one being their perception of the diagnostic quality of the image, and the third one being visualization of anatomic structures. And they asked very specific questions that were based on European guidelines for image quality, and that way it was a standardized tool that they'd be able to do some statistical analysis on and compare results among different raters, so let's say the radiologists versus the techs versus the students, and also their perception of aesthetic quality versus diagnostic quality, and did that differ. So what they decided was that they wanted image aesthetics to be included, and they wanted this category to be distinct from diagnostic quality. So the way I think of this is that when you're submitting images for your clinical portfolio during your hospital placements, your clinical instructor might reject an image even though it's diagnostic, but it's not optimal. So it may be not as aesthetically pleasing, but it's diagnostic. So those are kind of 2 different ways of rating an image. With respect to the visualization of anatomic structures, here is a snapshot of their question number 3 assessment tool that they use. So again, we'll just look at the questions that they asked for pelvis, but you can go back to the paper and have a look at this full list for each body part. So for the pelvis, they asked for whether or not there was a visually sharp reproduction of the sacrum and intervertebral foramina, the pubic and ischial rami, the sacroiliac joints, the necks of the femora, and the trabecular bone of the trochanters. So these are likely things that you've looked at when you're evaluating your images or doing image critique during your clinical practicums as well, and just generally making sure that you can see the particular bony details that are of interest, or soft tissue details if we're talking about chest or other structures. So let's take a look at the results. First of all, I just want to mention that I definitely don't expect you to know the statistical analyses, but it is important for researchers to communicate how this was performed, so that way there can be some validity or credibility to the study, and also the ability to identify limitations of the study and exactly what it was that they looked at and how they drew their conclusions. The narrative under the discussion helps readers understand the interpretation of the results, and that's where we should concentrate our efforts as not necessarily researchers, but as practitioners who want to have evidence-informed practice. So let's just focus on the results for diagnostic quality, because that is essentially what's going to determine whether or not this dose optimization strategy will be acceptable for use in clinical. So interestingly enough, for the pelvis, skull, and hand images, 100% of the radiologists passed the plus 20 kVp images. A few techs, however, did not pass the plus 20 kVp images for the bony structures. And this could have implications for practice. For example, if the tech feels the image is not diagnostic, then they'll potentially repeat it in an attempt to achieve a better image. Another interesting point was that a few techs also did not pass the images that were obtained at the standard technique. So that's the technique that they're normally used to seeing and using. The author suggests this could be related to workplace culture. So this is something that would be interesting for discussion after the article, and I'm interested to see what you guys think about your perceptions and understandings of adjusting technique and optimizing dose for your patients. Now let's look at the results for the chest. So on average, the radiologists rated the diagnostic quality of all chest images as a fail. So they didn't like the look of any of them. Techs rated all chest images as a pass. The exact explanation for this discrepancy is unknown. However, the authors mentioned that the chest is a more complex anatomic area, and that could have been a factor. One other point that they described was that one of the criteria used in the European guidelines for visualization of structures wasn't possible to be met on a phantom. So that might have factored into the way the radiologists rated the images. So now let's look at the dose savings. Overall, the researchers found that increasing the kVp by 20 resulted in significant dose reduction. But when you looked at the data for increasing the kVp by 30, it wasn't all that different to increasing it by 20. So essentially, it remained constant. So what do all of these results mean? Here are the 3 key points that I picked out of this paper. For pelvis, skull, and hand, increasing the kVp by 20 appears to be a highly effective dose optimization strategy for clinical practice, keeping in mind this is based on the techniques that were normally being used at this site and also for this particular system. For a chest, however, the standard kVp was already dose optimized in this particular system, and they were using 120 kVp, which is already on the higher end, particularly for a portable. And finally, increasing the kVp by 30 is not worth potentially compromising diagnostic quality. So you can think about some of the detrimental effects of a kVp that is too high, what that could do to the image. So some additional takeaways as far as what was the learning and what should you know, what's your responsibility as a technologist in the hospital. Well, here I've drawn from the resource from Health Canada, which is actually Safety Code 35, and I have the full reference listed at the end. And I've copied a couple of quotes here that you'll find in the safety code. So first, while regulatory dose limits have been established for radiation workers and the general public, these limits do not apply to doses received by a patient undergoing medical X-ray procedures. So basically that means that a patient could have a really high dose study one day and then they could experience some kind of trauma the next day. They're still going to have that imaging. It's always about a risk-benefit analysis to the patient. The second piece that I pulled out from the safety code is there must always be a conscious effort to reduce patient doses to the lowest practical level consistent with optimal quality of diagnostic information. So this study really emphasizes that by looking at a way that you can reduce the amount of radiation absorbed in the patient by increasing the kVp, but there's a certain point or threshold where if you start to lose diagnostic information, then that's where the limitation would lie. So here, increasing by kVp by 20 in some instances was effective, but it wasn't so much so for the chest because that was already dose optimized. The other piece I want to pull out is from a very specific section in the safety code, which talks about requirements and recommendations for radiographic procedures. And as technologists, it's really important for you to be aware of these guidelines in the safety code. So the one I wanted to highlight was the safety code does recommend using the highest X-ray tube voltage or kVp possible, which produces images of good quality. So this is something for you to keep in mind, just your understanding with kVp and how it affects dose, as well as what your responsibility is as a technologist in trying to adhere to the ALERA principle. So I've put some points to ponder for you here, just to make this seminar experience a little bit more interactive. And I have some questions for you that I encourage you to chat with each other, perhaps in your course discussion or in an online group setting. And the first question is, what was the purpose of rating perceived aesthetic quality? Why did the researchers want to include this? The second question I have for you is, how did the techniques at your most recent clinical site compare to the standard techniques in Table 1? And it may be most relevant to think about what techniques you are using for mobile exams, since that's the type of study that they looked at here. And finally, I'm curious to know what opinions or understandings that you have formed about dose optimization in a clinical setting, if anything at this point yet. Hopefully you guys enjoyed that seminar article review. This is an article that I've been using for the last couple of years, and I know other instructors have used this one as well. I feel like it's a really good sort of refresher of what you know about kVp and mAs and dose. And also it's quite practical as far as the types of things that you might look at in a clinical setting and how do you apply these concepts. So as a little bit of a bonus here, I would like to introduce you to something called the kVp test. You may have heard of this before in other research-based lessons or projects at other courses or other programs that you've taken. So what is the kVp test? Well, when you search for information, you're going to find lots of it, but the question is it good information? So the kVp test is basically a list of questions that can help you evaluate the information you find. And when you look at the list of questions, I will have a link for you if you'd like to use this activity. You'll notice that some criteria may be more or less important depending on what your actual project is. And in this case, you're being asked to look for a peer-reviewed journal article, so that's a little bit different than looking at a website, for example, or a blog or something like that. But nonetheless, this could be a really useful tool regardless of what type of source you're looking at. So just as an example, let's just go through what kVp stands for and do a little bit of a kVp test on the article that I selected. So the first letter is C, and that stands for currency, and that's basically referring to the timeliness of the information. So when was the information published or posted? Has it been revised or updated? And does your topic require current information, or will older sources do? So that is a really important question when you're thinking about radiographic equipment and technology, because we know that it's constantly evolving. So something like kVp and mAs and the fundamentals don't really change over time, but depending on which question you're asking, you might want to be considering, well, is the technology that they're using in this study still the same type of technology that we're using? in today's practice settings. The next category is the relevance. So the importance of the information for your needs. So does this information relate to your topic or answer your question? Who's the intended audience? Is this information the appropriate level? And have you looked at a variety of sources before determining that this is, let's say, the article you're going to use? The next one's authority. So this is referring to the source of the information. So really, who is the author? Who's the publisher? Did anybody sponsor this? And what are the author's credentials? Are they affiliated with any academic institutions, for example? Are they qualified to write the topic? And this is a really important one not to take for granted. The next one's accuracy. So is the information reliable? Is it correct? So in the case of this research study, we had disclosed statistical analyses, so we could see exactly what they did. They described their methods very clearly. So you can make a bit of a judgment on whether or not, based on your expertise, if you feel like what they did was valid. And this is helpful when building upon research and citing sources for future information gathering. And then finally, the purpose. So the reason that the information exists. So we talked about the purpose of this study was to investigate dose optimization strategies, but ultimately it's really to figure out how to put best evidence into practice. And this is directly in line with what we're trying to achieve as technologists. So there you go. Is it crap is a question that you should be asking yourself when selecting your seminar article. So let's just take a quick peek. Most of the information that you need to answer this question, at least a lot of it, truly is in the actual sort of title or intro component to the article and the abstract as well. But it is good to kind of skim through and read over the article with all these things in mind before you do a deep dive or a deep read into all the details. So going back through the category, when you think of currency, well, this was from 2015. So it's not that old, but you definitely want to be careful when you're looking at X-ray equipment, like I mentioned, just because technology changes so quickly. So that's something you'd have to assess based on the topic that you're interested in. And then the next thing is the relevance. So we know that this is highly relevant to what we're trying to learn, not only in the course, but also just in general as technologists and on our responsibility to select technical factors, but also contribute to this type of information sharing within your department. And as far as authority goes, well, the authors are listed here. You could actually go on the website and you can click on their bios and you can see that they're all affiliated with an educational institution. And I also wanted to point out that one of the authors is in fact an MRT. So it's always really great to see an MRT participating and providing that lens, as well as physicists or that. And also thinking of who they recruited as their study participants. Well, radiologists and radiographers are looking at images, so they would be the ones that should be evaluating and making this decision of whether or not the images were acceptable. And I also wanted to point out that this is a peer-reviewed article that was published in the Journal of Medical Imaging and Radiation Sciences. So that adds even more credibility to it. And that can contribute to as far as your ability to judge the accuracy of the information. And then you can also see that this has been labeled as a research article. So that ties into what was the purpose of this? Why does this information exist? And there you have it. So if you're interested in using this tool, here's a link to the full list of questions, and you'll probably find that a lot of libraries also cite this as a tool that can be used by students or anyone who's really trying to look for sources of information for various purposes. And there are the references that I used for this presentation.